going to get started. Hello, everyone. It's time to get started with this panel. So my name is Raha Masoudi. I use she, her pronouns, and I'm joining you all virtually from the traditional and unceded territories of the Coast Salish people, in particular the Squamish, Tsleil-Waututh, and Musqueam First Nations, to whom I express my utmost gratitude. I'm a research assistant with the Addictions and Concurrent Disorders group with Dr. Professor Michael Kraus, and I would like to thank all of you for tuning into today's panel. I can't express how excited I am to hear from today's group. These individuals are doing some incredible work within the field that I'm sure inspires many of us who are joined here, and I'm honored to present them all to you today. So firstly, I'd like to present Dr. Jennifer Russel, who is the Associate Head of Psychiatry, Child, Youth, and Women's Reproductive Mental Health at BC Children's Hospital. Dr. Russel has experience as the Director of the Child and Adolescent Psychiatry Compass program at BC Children's and is the co-founder of the Psychological PPE program with Tend Academy, an online program that provides evidence-based strategies and tools to protect emotional and mental well-being during exposure to high-stress, high-pressure situations. Next, I'd like to present Dr. Vijay Seethapathy, who is the Chief Medical Officer of BC Mental Health and Substance Use Services. Dr. Seethapathy is a Psychiatry Fellow of the Royal College of Physicians of Canada and is certified in addiction medicine by the American Board of Addiction Medicine. He has clinical expertise in assessment and management of complex concurrent disorders, ACT, and acute psychiatry. And our final panelist is Leslie. Leslie, is she here? Leslie, I think she is here. Leslie Mcbain, who co-founded Moms Stop the Harm in 2016. She is the family engagement lead for the British Columbia Centre on Substance Use, and Leslie sits on several BC provincial and federal committees dedicated to changing drug policies. So now I'd like to take this opportunity to give each of the panelists an opportunity to introduce themselves. So maybe we can start with Dr. Russel.
Oh, thank you, Raha. I guess you've already introduced me, but maybe just to add, I really appreciate being asked to be part of this talk. Even hearing the questions was inspiring for me, and I especially appreciate having the opportunity to present with Vijay and Leslie on this topic. So, in addition to being a psychiatrist, I'm also a mom. I have 2 kids, and I think that's important when we're talking about advocacy because our personal life also intersects with our professional life. And I'm particularly interested in how we can overcome barriers in healthcare, specifically for children and youth who have less access to care, either because they live in remote or Indigenous areas, or because there's systems barriers that are affecting their ability to access care, and how we can use research or evidence-based treatment to better improve care. So that's a little bit about me.
Awesome. Thank you, Jennifer. Sorry, also my computer just glitched a little bit, but maybe next, Dr. Seethapathy, would you like to present yourself and a bit about the work that you do?
Yeah, I know. Thanks, Raha, and I really appreciate again, similar to my colleague, Dr. Russel, that I really appreciate, and I'm happy to be here and be part of the panel. I mean, you already given my bit of a background introduction, so I could just add a little bit more to it. So I do work as a psychiatrist in clinical setting in addition to my chief medical officer role. I do interact with really complex and underserved client population, I would say. I mean, particularly in correctional health services, where we have a large surge of people going in and coming out within BC, and also with complex concurrent disorders, so-called like people suffering from mental health and addiction, the Redfish Center for Mental Health and Addiction in the River Big Ground. So I do work in the front line, and I've been a strong advocate. Been in Vancouver for about 10 years, and come from UK. And I've been a strong advocate, particularly looking at those gap in services that is essentially required to kind of to match the demands and needs for the entire continuum of care. I mean, it's just not just one piece, and we always kind of quite heavily involved in one piece, but I'm always interested in looking at the entire continuum of care and what needs to be put in place in a medium to long-term solutions. And I'm happy to kind of share a little bit more as we kind of go along. Some of the work we've done and some of the work I aspire to do going forward. I mean, it's never ending, and we need a lot to do here. And I'm happy to be here with Leslie and Jennifer here. Thanks.
Thank you so much. That was amazing. So finally, Leslie, would you like to introduce yourself and talk a bit about the work that you do?
Yes, I would. And yes, thank you for inviting me here. I am not a doctor. I'm not a researcher. I am a bereaved mother. I lost my only child, my son Jordan, in 2014 to a prescription drug overdose. And after I was able to lift my head again after that most tragic event, I purposefully met two other women who had lost their children, their sons, to drug harms. We did start Mom Stop the Harm in about 2016. We can't even remember the actual date. But what we advocate for, and again, as the doctor said, we will. I will talk about this more later, but we advocate first and foremost for a safe supply of drugs for people who need them. Our main thrust, we have two actually, but the first one is to keep people alive. And as we always say, dead people don't recover. And also secondarily, we support families who have lost someone. We have support groups, and we have support groups for people who have their loved ones still with them and are struggling with substance use. So I'm an advocate and great supporter of families who need us. Thanks.
Thank you so much, Leslie. So I want to just say welcome to the audience members who are trickling in. So today's presentation is going to be a panel. So I prepared some questions for our incredible panelists. And if any of the audience members have any additional questions, feel free to ask them in the Whova chat. But I think we should just dive into it. So my first question to the panelists is, based off of your experiences, what is the value of advocacy-based research within this field? How have the two informed each other, and why is an informed perspective so important? So we can start with anyone who wants to chime in, or we can go in an order. Does anyone want to start?
I don't want to start because I have to grab my first page of notes from my printer. So ask someone else to be right back.
Dr. Russell, would you like to get things started then?
Sure. So I think it's even an interesting concept for me to hear advocacy-based research, because to me, research in itself is a form of advocacy, where you're exploring a topic and getting evidence and then putting it out there in the world is in itself, and I think a measure of advocacy. For me, I think the most important connection of advocacy with research is really what is the most clinically relevant to the people that we're trying to support as physicians, researchers, healthcare workers. I worry sometimes that we can go off on tangents that we think are important and actually miss what is actually the most important to the people that we're trying to serve and help. And as Leslie so astutely said, keep alive. And if there's too much of a gap between what families, youth, and the people providing the care on the ground actually need, then the research might not be as effective or as relevant as it could be, because we have very limited resources. So we have to really pick what it is that we're going to study, what it is we're going to explore. I think having different perspectives, like on research grants, for example, when was the last time that people with lived experience were part of the panel of choosing what research got dollars? And we talk a lot about having people with lived experience as part of the healthcare team, but are they really? And by that I mean like at the table where dollars are spent, where decisions are made, where priorities are chosen. And I think this is where we need to head to really what do our patients and their families need, and then how do we walk alongside them, really coming together with their expertise of lived experience, with the healthcare team's expertise in their different areas, to collaborate.
Thank you so much, Dr. Russell. Dr. Seethapathy, would you like to add on to this question?
Yeah, no, but thanks for sharing eloquently, Dr. Russell, about your thoughts on that. And to me, like, when I got invited to the panel, the question arose, I had to kind of start digging my research work into, how do we kind of do this thing together? Although I realized, like, once I started to read more and more into the topic, that we do this every day. I mean, all of us, whether directly or indirectly, whether focused or in a broader fashion. To me, that, particularly when you work in mental health and substance use, and in my area, working in complex population group with a lot of vulnerability and an underserved clientele, what we see day in and day out, there's very little in terms of the actual research that makes a change or makes a change in their life, because most of the research has been focused primarily on, proving a hypothesis or finding a truth, or medication-based trials and everything else over the years. But when I came to BC and started to look at this complex population group, clearly we definitely need the research to kind of pull and create that base and create that argument and create that evidence. And then using that research base, once we have the stats and numbers, and then what do we do next? So that's the question. So that's where the advocacy-based work comes in. So you could say that, the research starts first and the advocacy goes next, or you could just say in some area, the research and advocacy should be hand in hand and they have to kind of start from the beginning. In some areas, like, they're so intermixed that you cannot separate them at all. So to me, like, the work, what we have done in the need-based population-related work in mental health and substance use, figuring out, what is required for certain diagnosis and certain clientele, certain group, the research work starts intermixed with advocacy right from the beginning. So to me, it's not just hypothesis to prove. It is like, what are the influence we want this research to have in terms of policies, in terms of funding, in terms of resources for this particular population and for the services for the particular population. And I can give a quick example. I mean, when I was working in Vancouver General Hospital, and I was really appalled by the waiting time and the access for the mental health care in BC. And I was doing a module with the Sauder School at the time. And then I thought an interesting project would be for me to start to look at how do we improve the access and timely access for the healthcare, and what do we come up with? And when it comes to any new services, it's always about the money. So like Dr. Russell was saying, the dollar spent, how do we strongly advocate and lobby the dollar to be spent to have the most value add for the services what we are trying to intend? And what we did was we actually went and did a bit of research and got some stats and numbers onto the waiting time and the increased waiting time in ER, the increased waiting time for the police, increasing waiting time for communities for clients who require that mental health assessment. And it was really, really compelling for us to put an argument. So we started to kind of do a bit more background work and start to look at the different service models, which actually works on improving access, and mirrored a model from UK and brought the model and then proposed it, and then set up an access and assessment center, which gave a 24/7 access to a psychiatry and psychiatrist-based assessment care in Vancouver General Hospital. So the reason I'm actually bringing that along is I'm not an academician primarily, so I would say that I'm an healthcare advocate, to be very honest. Although I'm a psychiatrist, I'm a doctor. Like Leslie was saying, like, I'm not a doctor, but it doesn't matter to me. Like, I don't put my doctor's hat when I start my advocacy work. To me, like, I put myself in the clients and the families and the PLE and start to look at what is really required. So this has been reflected in many new services we have actually built over the past decade during my work with both Vancouver Coastal and also with the PHSA in forensics and correctional team, and also with for the access services in VGH. And one other service was the community transition teams, people coming out of their corrections require that urgent and immediate timely connection and bridging team. And we strongly built a case. We built the numbers and the research-based statistics. And then we strongly advocated for building 5 to 10 teams now. So we got every correctional center has got a community transition team, which connects the clients with substance use and mental health problems to the care they need in a timely fashion when they are released back into community. So I can kind of go on and on, but what I'm trying to get to is it is such an important piece of work, and particularly in the mental health and substance use area, it is important in every healthcare aspect, but more so in the mental health and substance use, where we need to kind of apply the lens of advocacy and research all the time, and it has to be part and parcel of our work. Thank you.
Thank you so much, Dr. Seethapathy. That was incredibly insightful. I guess moving along, I want to address Leslie. Leslie, your work with Moms Stop the Harm was actually one of the factors that inspired me to get involved in this field of research a few years ago. So I continue to be moved by your team's work and mission, and I feel especially honored to be here with you. So you've demonstrated that collaboration and community can bring about tangible change for so many people, and this is a huge source of inspiration for me as an individual within this field. So I would like to ask all of the panelists, kind of it's a sideline question, but what inspires you to do the work that you do? So maybe Leslie, do you want to briefly touch on what your source of inspiration is?
You know, it's hard to it keeps changing. The inspiration changes, and of course, when my son died, and when I got back up, that was the inspiration. The inspiration there was for the three of us who co-founded Moms Stop the Harm was we did not want any other mother to go through this. That was our guiding inspiration, our principle. So we didn't know where to start. We'd never done this before. Like, how do we do this? And so we just dived in, and we, you know, got onto some committees and so on and so forth. Then the inspiration becomes, how do we actually move government to change policy? And so, you know, being the moms is kind of a good thing. We're not, you know, people feel comfortable with moms Stop the Harm, and also moms are a strong voice. So as our organization grew, which now we're almost at 4,000 people across Canada in Moms Stop the Harm, this is a huge number of stories. It's 4,000 stories, and these stories are incredibly valuable. They are stories of day-to-day struggles with someone who has mental health and substance use issues. It is stories of death. It is stories, moms who have lost 2 kids, if you can even imagine that. I mean, we have a huge cohort. We have a zillion stories. We have people joining every day. And to me, this is an inspiration. It means that we are doing something right. We are filling a need. And also, we have been asked by several researchers for our input, and we've been included in some research reports. This is inspiring as well, because it shows that people who do research and physicians and so on do care, do want to also make the same kinds of change. I think that answered that question. I have other of your questions which were very inspirational to me. I had to read them like 3 or 4 times and get my colleague Kevin to help, excuse me, to help me with what does this exactly mean? So I have other questions that I want to answer, but I'll wait for my turn on these. Thank you.
Absolutely. Thank you, Leslie. That was incredible. Do the other panelists want to answer this question, or should I move along to the next series?
Well, I can maybe chip in just a few things. You know what, Leslie, that was
Sure.
quite moving, and I was just reading about your work over the years, and incredible piece of work and strong advocacy you led. Hats off to you. Not easy, particularly in that field where and difficult after losing a loved one. So I just want to kind of share maybe a couple of quick examples here. And the way I look at it for inspiration, and where I kind of draw up my inspiration is the day-to-day work. You know, what I see with my work with my patients, and work with my clients, work with the families. And what became really a game changer for me when I came to Vancouver about 10 years ago, I would say that, there's two levels. I mean, one is at the individual level, another at the system level of the examples. And one of the example I would give is a patient who I used to work with. And everybody used to say in downtown East Side with the ACT team, and they say, this is baseline. So, and then they would just see the client, discharge them back to the same inappropriate or an accommodation or a placement that is really, really not suitable for any recovery or a treatment modality the client would require or need there. So we strongly advocated for the longer stay. And we also found that, through that, we had to kind of create again a background, some work, and found out that there has to be some subsidy attached to some of this complex clientele services, what we need, and we need an appropriate placement. So this particular client came to me and said, Dr. Vijay, this is the very first time I've had a home and then also have a washing machine at home and a dishwasher that I can actually wash a dish. And that was really, really moving. I just want to kind of bring that individual touch, what it gives, and the story, which is really powerful. And if you don't hear that, and you would say, okay, it's a roof over the head. No, it's not just a simple roof over the head. It's some of those comforts, what they feel is important to the clientele, and how strongly advocate for the subsidized accommodation options and the funding attached to the complex teams when it's required. And then I took the same principle, and then we started, or we got the funding approval for the first ever forensic ACT teams in the province just a few months ago. And we'll be running that forensic ACT team in the South Fraser area starting end of this year or January next year. And this is to connect that civil and forensic interface clients who do not really fit anywhere in the service. I mean, they're too unwell to be with the civil services, and not that aggressive or violent or not on the legal order to be going under the forensic, but nobody wants to kind of take care of them. So, and we strongly put in that subsidy attached to that housing model for the 30 clients. And we were successful, not just providing the care team, but also a successful subsidy attached so that we can actually find a roof over the head when we're going to work with a client. And then that inspiration came from the client who I worked with in the downtown East Side about 8 years ago. So that's one example. And the second example I would just very quickly, is not to take too much time, would be the system level changes. And when I started to work as a resident, as a trainee, I used to moan and groan about all the services around me and say, no, this is not good, that's not good, this is never great. And then I had a mentor and who was a supervisor to me and said, hey, Vijay, you really want to make a change. Some people can advocate for it, and then looks like you can. So you be the change. You show what you can do first, and then the change will follow through. And then that started with my system gaps. And then I also wanted to kind of put the seniority cap and some credibility cap. So I went and did my formal MBA to kind of show that I can write some business cases and work through the system level planning. So I completed that, which was not easy. So going through that system level changes, you also need that credibility and some kind of, I mean, they always say seniority. I mean, I'm not too old yet. I really don't want to think that way. But we made some successful changes and made some impact. And then we see that the policy makers are now reaching out and asking us to give input and consultation. And then we've been actively involving person with lived experience and families in many of our research grant proposals in the recent times through PHSA. Thank you.
Thank you so much, Dr. Seethapathy. Dr. Russel, do you want to chime in on this question as well?
Yeah, these are, even hearing these answers are inspiring for me.
Very inspiring indeed.
You know, I think for me, what keeps me, I guess, going or passionate about this work, and maybe as a child psychiatrist, I have a bit of a unique perspective in that often I'll meet a child or youth or their family at a real crisis point in their life, you know, a suicide attempt, you know, a drug overdose that luckily I think we were able to resuscitate. And in all of that pain, I also hold the experience of seeing other children, youth, and families recover. And most of these disorders in child and youth mental health, at least, including substance use, are very treatable. So it's being able to meet a family in pain and have the lived experience of a similar family doing well. And so it's kind of both at the same time. And so it's very inspiring to work with young people and their families who, you know, often in crisis, there is also so much love, so much, you know, underneath anger is love, right? Like people care. And that, I think that is like having the opportunity, it's really a privilege or a gift to be part of a family's journey. And to get like the card that so-and-so graduated, so-and-so got married, someone got their first job, someone is, you know, going into, you know, nursing, or those stories are really rewarding, and you hold them in your heart as a person. And so for me, that is also where research and advocacy and clinical work and really being a human all come together and fuel at least me day to day.
Thank you so much, Dr. Russell, and thank you to all the panelists for your incredible responses in different ways, and how, I guess, stories center the work that you do and inspire you to keep on pushing forward. That's amazing. Thank you so much. So my next question to you all is, what are the barriers or challenges in integrating advocacy and research, if there are any?
I will say that a barrier for me that is often not talked about in psychiatry, at least, but I don't consider myself like a researcher. I participated and supported other people in their research, but I sometimes feel the term research is so daunting. It feels like to, you know, apply for funding and to apply for ethics, and that there's like numerous hoops that people have to go through over many years, and then at the end of it, even to get whatever you've done published, sometimes feels daunting to me and overwhelming in the midst of like an already crazy busy schedule. Now that these might not be the barriers you're asking about, Raha, but like I do wonder how people are able to do it, like with especially like when we look what's happened in our healthcare system the past few years, where the patient volumes and need has been like overwhelming. How people carve out the time, sustained, you know, and there is a specific skill set, I think, for clinician scientists. So for me, those are some significant barriers.
Yeah, I'm glad you brought those up, Dr. Russell, and I think they're well worth mentioning. And I think that many of us here can definitely attest to, I guess, sometimes how frustrating it can be to do work that you want to do. So thank you for mentioning that. Dr. Seethapathy, is there anything you want to mention in terms of barriers or challenges that you've noticed?
I want to try and I kind of talk to myself and say I'm going to keep my discussions crisp, but I can never practice that. So I always kind of go about in a roundabout manner. So just stop me if I'm going lengthy. But I have to say that, you know, I completely agree with Dr. Russell. I mean, it's daunting. I mean, the word research, the meaning of research, the immediate thing what you think is, oh, it's going to take months or years to get this approval. Oh God, what am I going to do with this ethics, and what I'm going to do with the funding, and am I going to get all the approves or not? Going through the process. What about the time? I mean, with the busy lives, what we do. I mean, I completely agree. Like, you know, that's really daunting. And that is one of the important challenge what I see clearly in terms of the process and steps, and also the timing, what is available in terms of the clinicians and clinical people who want to kind of do this piece of work. But nevertheless, I mean, the way I look at it would be, I mean, I've been through some of this ups and downs and lows and highs in terms of advocacy and research work during my clinical career. And what I've actually found is, I mean, you can't do everything yourself, and you need to find allies, you need to find partners. it's not easy to kind of find who they are. I mean, that could be a challenge to say who could be the right allies, who could be the right partners, and kind of making sure that this is going to move forward. So just understanding the political landscape, understanding the local landscape, who do I link up with, and where do I make sure that the best bang comes out of this when I start to do this work. And also looking at the political scenario, the policies and the strategy where things are getting driven, and how we can make an influence on that. Also the local organization, I mean, where I work in, I mean, it's not always helpful for people to go completely outside the organizational mandate and strategy, what we're working on. So I think depending on all those areas of people's own beliefs, people's feel that, you know, they want to kind of move things forward, but finding time, research itself as a process, and finding those allies and partners, funding, those are issues, and also getting the right skill group of people coming together to kind of pull all those things together. Like, you know, I want the statistics and I want the data, but where do I get the data? I mean, the data is not even available. There's very poor quality. So I think kind of getting all those pieces is, I mean, we could just start listing those challenges a lot. But the key thing is, what I would say that the take-home message I would give is, the challenges are there in every aspect of work, what we do. I mean, whether it's a research or advocacy, or whether it is the day-to-day clinical work, or finding an accommodation for a client, or finding some funding sources to support them, and et cetera, et cetera. But what I've actually found is, form the allies, do your groundwork, keep everything ready. When the timing comes, hit the bell. So that's what I actually found is much more helpful than keep shouting and screaming all the time. To me, like, you know, that really takes energy off me, and I was able to reasonably be successful with some of the initiatives by keeping all the ducks in the row, and waiting for the moment, and then pounce on it, and we actually get more than what we asked for sometimes.
Thank you so much, Dr. Seethapathy. That was really insightful, and I guess it's inspiring that you're so well prepared for the necessary moment to arise. Beautiful. Leslie, do you want to talk about any challenges or frustrations you have had working in advocacy? If there are any that you want to talk about.
There are, and I like both what Jennifer and Vijay have said, and I love that idea of being all ready to just jump on it. That's great. One of the issues that I see is distrust, inherent in people who use drugs of academia, of the medical system, of anything that has to do with any kind of system, because they have been kicked around and kicked out, and, you know, just, you know, not attended to for so long, that to find people who can and will tell their stories and will participate in a way that you need, you know, that researchers need, is difficult. And I don't blame them at all. I mean, they have good reason to be mistrustful. So I think for researchers, for doing your research, it's really important to make the connections, to find a mentor, to find an advocate that can help in finding the people who will inform the research. So yeah, trust is a huge issue. The other barrier, of course, is, and I don't think it applies to people in this room, but is the stigma around drug use. And this is what, you know, the stigma of that the public has informs the policymakers. The policymakers have their own stigma, but they are, you know, they're supposedly listening to their constituents. And so the stigma just goes all the way to the top. And, you know, the lack of value, I guess, of the people who use drugs, the people who have substance use disorder, or are, you know, just overdosing over and over again. The devaluing of those people because of stigma is a huge barrier to funding, you know, to policy change, to everything. So I see that as a huge barrier. And we at Mum Stop the Harm, we worked really hard on the committees that we're on, and yeah, where we have a voice, destigmatizing drug use, and again, you know, advocating for a safe supply, which will cut through so much of the crap that is in the way of people surviving drug use. So I could go on and on about this, but we need to reduce the stigma. We need the research. And I want to bring up too, and I think this was in the first question, but what was the first question? It was like, based off your experience, what is the value of advocacy-based research? I want to bring up two things. Well, Insight, for instance, is a really good example of a bunch of people, committed people, going rogue, starting a safe consumption site, letting it roll, not being shut down. Well, maybe I know there was issues. And then finally, the government legitimized Insight. And that there's now over, I don't even know exactly now, but around 40 safe consumption sites in Canada. And more are being approved every day. Well, not maybe every day, but often. And also the OPS, you know, overdose prevention sites, which are different, but just started by going rogue. And so the advocacy then informs what research needs to be done for funding, you know, for not closing the doors and so on. So, and there's more. I mean, decriminalization, for instance. I'm still on the committee for, even though we did get decriminalization in BC, we aren't happy with it. We're happy that it happened. I mean, it's a huge step, but it was advocacy that drove, you know, the government to actually talk about it. And the government came down with a decriminalization that is somewhat flawed, but it's a place to start to work. Yeah, so, and we're hoping for that safe supply. You know, the research is dribbling in, but it's advocacy inspired. So yeah, I think we have a strong and stronger voice, and especially with the number of people dying. And it's actually crazy to me, and I'm not going to say it keeps me up at night, but I think about it every day, how the government is actually letting people die. And the way I look at it is they've made a decision. Well, let's do lots of recovery centers and increase the number of beds and increase the number of safe consumption sites and all harm reduction, which is great. We need it. Band-aids on a flowing wound. But the one thing they could do to stop the deaths, they are not doing. And that, I'm way off topic here, but that makes my head explode, honestly. So that's all I have to say about that. I don't even know where I started, but thank you for listening.
Thank you, Leslie. That was incredible. And I think your answer just spoke for itself. That was really, really powerful. And I was waiting to hear that from you. So thank you for sharing all of it.
You're welcome.
It was really, really beautiful. Yeah, just
Raha, could I comment on something that Leslie brought up?
Absolutely.
I think this concept of stigma is really at the heart of all of this. Mm-hmm. And I 100% agree with what Leslie's saying. And I think that with mental health and substance use issues, there's an us versus them dichotomy that I think people think it's them. Like, it's not going to happen to me or my family. And we would look at how, like, the COVID pandemic was handled, where everyone was vulnerable, like we're doing global public health initiatives to curb a pandemic. But more people, I understand, in BC, I don't know the exact data, are dying from opiate overdoses. You know, why are we not standing? Why is Bonnie Henry not up there saying 5 people died of COVID, 20 people died of opiate? It's like it was a monthly tail on, at the end. And I think this concept of stigma, it's like really everyone that I know has been affected by mental health and or substance use. It's not an us versus them. It's a everybody. No one is immune. There's, anyone can develop these issues. But but yet we're not able to really admit it in a authentic way, which I think has allowed governments to push this off the agenda. Like, it hasn't been a priority. You know, when I look at how, like, would these deaths be acceptable if they were coming from like childhood cancer or something else? Like, our society would not accept that a child could not get into treatment for, you know, leukemia within so many months, or if there are changes that could be made, but yet somehow in mental health, these things are acceptable. And so I really wonder, like, well, how do we change the way we're talking and in a very personal but high level, because then these things reflect decisions that are made at tables far higher than I sit at.
Yeah. Could I just add one thing? Thank you, Jennifer, because that's exactly right. I just want to comment on the term opioid crisis. It's actually today, and has been for a few years, a toxic drug poisoning crisis. No longer is it just opioids, it's tainted drugs. So we wonder where Bonnie Henry is too in this, like, because she used to be right beside us, you know, carrying the flag. But anyway, we call it a drug poisoning crisis because that is what it is now. It's not just opioids and overdose. Those are the terms we use, but we're just trying to move the needle a little bit on that terminology. But thank you. Yes, I agree 100%. Thanks.
Thank you to both panelists.
Raha.
Okay, yes. Good.
Hey,
Yes.
just have a quick comment to make. I know I
Yes,
just
please
can't
do.
stop. I mean, this is an inspiring moment for me to kind of add a
Of
few comments
course.
from my end, from Leslie and Jennifer. So I fully concur with both my colleagues here and both my panelists here, and I would support them with their advocacy, what they are highlighting, and the importance of the substance use care and the overdose crisis and the toxic drug crisis we're going through. And also, like Dr. Russell was talking about, the mental health related issues overall, even on children and youth, and all those areas. But I just want to kind of slightly give a perspective what I see, and I've been advocating more recently. I mean, using some terminology called palliative psychiatry right now. So I think we are really moving away from preventing early access to crisis intervention, firefighting, and almost like keeping people at the deathbed of the mental health and substance use care. And we are moving into a palliative mode rather than an active work on the entire continuum, what is required. So I've come across, I mean, as a psychiatrist and as a clinician working with both mental health and substance use client, I do see young people coming through the door, like, 21, 22, 23, 24. And I do see an opportunity missed when they were 17 and 18, when they're drifting off due to the underlying problems, what they're facing. That there could be many, it could be social, could be psychological, could be psychiatric, could be trauma, could be stigma. But I think the important piece is, while we advocate for all the immediate measure that's really needed, a sense of urgency, I would really like to see a provincial 10-year plan addressing this and building blocks and looking at our entire access, early intervention, as much of prevention work and public health work, while we're putting the money on crisis intervention currently to kind of combat the crisis. So I think we're really shooting in the dark repeatedly, and then we are really firefighting. This is what it's incredibly frustrating for me as a clinician, as an healthcare advocate in BC, and which is necessary, but we're really not taking a time to step back and say, we need to do that parallelly. We need to kind of create a system which is going to prevent these crises in the future. We're going to give early access, early intervention to our kids and young adults who are coming through the door. And it is a stressful environment, stressful world. The current younger generations don't have the resilience and coping skills what they had. So they end up in different paths. And we need to kind of start to have a 10-year plan for both mental health and substance use, and what the province should look like. And if we don't have the strategy there, and we're doing a piecemeal strategy all the time, then we're really not hitting the nail on the head. And then we're going to continue our palliative care for the years to come.
Thank you, Dr. Seethapathy. given that we have 12 minutes left, I think that I'm going to ask 2 more questions. I'm going to first ask the final question that I sent to you guys, but are there any particularly interesting or groundbreaking research projects or advocacy groups outside of your own work that you would like to share with the audience or feel like they should know about? Does anyone want to talk about something that
Sure.
they find really interesting?
Well, I want to talk about, first of all, I want to talk about DULF, the Drug Users Liberation Front. And that is a group in Vancouver who, again, are going rogue. They are purchasing illicit drugs off the dark web. They are testing them to the nth degree to make sure they're safe. And then they're distributing them basically on the street. They are amazing. They're starting to do their own research with a small cohort, but even in this preliminary stage, they're finding amazing success. Nobody's died, first of all. What is the happiness sort of quotient of the people who are using these drugs? How do they feel about themselves? How are they is there diversion? I mean, there's all kinds of things that they I'm on their committee, or not on their committee, but within their group, so I get to see this. Probably not extremely professional research, but they're just through their numbers. DULF is going rogue. DULF has applied for an exemption from the federal government to do this. They've been denied. They are bringing a lawsuit to the federal government because of that. So here we go. In a direction that we need to go in, but with this small number of very committed people who use drugs. And so anyway, I just want to bring that up. Also, I had, if people want to know more, DULF, D-U-L-F, Drug User Liberation Front, they have a website. VANDU, the Vancouver Area Network of Drug Users. I put down Prairie Harm Reduction. They're in Saskatchewan, but they're a really good group again. And then the Canadian Drug Policy Coalition, of which we are a member. So there's amazing groups out there doing an amazing amount of work advocating for the safety of people who use drugs. So I just want to bring those up. But I also want to say to Dr. Vijay, absolutely, we need, and we keep trying on this, but it's really hard. It's like there's a big moat around the Ministry of Education. We need in the schools qualified counselors or people who can see children who are vulnerable, let's say, and the ones, and I know some personally, and it just breaks your heart to see a trajectory going on, but to get the information into the schools, we can do that. We've come into schools and we talk to high school and middle school about drug safety and so on and so forth, but that doesn't address the reason why people use drugs. And my son had ADHD, as many people who use drugs do. Drugs settled down his brain. He felt normal when he could access opioids in particular. There's so many kids out there that we can help if we can see it and if we attend to them. So I just want to say thank you for that. Yeah, the early intervention. And Jennifer, I know you know this as well, but that is really the ace in the hole if you want to catch early issues.
I couldn't agree with you more. I think the siloed approach of the ministries, where we have like the Ministry of Education, Ministry of Health, Ministry of Child and Youth, like they're so separate, whereas like where are children and youth? They're in the schools. And how, like, that's where people are, like, they're not at BC Children's, they're all at, like, some of, like, a very, very small number are here. Everyone is pretty much at the schools. And how do we break out of our silos and come together in a way that is way more holistic and family-centered, and seeing people, where they feel safe and comfortable with teachers and guidance counselors that know their family and them over time. I think there's a real opportunity for prevention You know, when I hear people waiting, like this comment, oh, we waited till grade 3, we waited till grade 6. I'm like, who told you to wait? Like, where did this concept come from? Like, if a parent or teacher is concerned, it should be investigated. You know, maybe they're wrong, maybe there's nothing, but why not assess the child? Like, why wait? Why have people suffer until they're 3 years now behind in school, or they've, you know, had an emotional outburst, or because most of this stuff there is really good treatment for. So I think that's an area of like integration is an area that we really need to advocate for.
Thank you, Dr. Russell.
I was just going to say, one of our moms who has been invited as a team, there's 2 of them going into high schools in Kelowna. She had to go in front of the school board, or the school district, I think it was, leadership. And and she is one of the moms who has lost 2 sons to drug harms. The person in charge asked her, so what makes you qualified to talk to kids? You know, and my friend Helen just about, you know, she had to just bite her tongue. How could we be qualified? Well, let me tell you, you know. So anyways, that's another, you know, it's a part of the silo, you know, or part of the barriers to getting, and I understand schools have to keep kids safe, you know, from us moms and other dangerous people, but that happened.
Thank you, Leslie, for sharing. Dr. Vijay, do you want to mention any projects outside of your own work that you find are worthwhile with sharing with the audience?
Yeah, you know, I can definitely kind of mention a few of them across and where they are trying to find their voice heard. I worked with both local organizations and also with national level organizations, including societies and CCSAs and commission on putting proposals together. It is quite warming to see that we do have a call for based on substance use and substance use innovation, with the recent call for from the Mental Health Commission and CHR. So I think there are academic institutions and organizations who are hearing the problems at the local level and then trying to bring in innovative ideas and research methodologies, and even strongly recommending they have to partner with nonprofits and persons with lived experience and families as part of their application. So which is all really heartwarming and progressive. And I see like, you know, we could see a lot of changes happening. But I really want to come back and bore again on the same subject, what I've been mentioning. So over the years, I mean, even if you want to kind of plan to build a house, you want to have a plan. So you can't kind of build a house or build a family or build a community or build a system without having a plan or a blueprint for what we're going to do for the next 5 years or 10 years. So to me, we are in a crisis mode. We've been in a crisis mode since the time I came here in BC, either from mental health access or substance use or COVID or toxic drug crisis. And then going back again, talking about what are the problems within our community. One is the equitability of the care. I mean, I go to Fort St. John's and Williams Lake and my heart comes out, really, to be honest, and they have absolutely appalling access to care. And we come to downtown and we say, okay, we're putting all the money and putting it, but we're not hitting the nail on the head, and we are actually missing a lot of pieces. So my question comes back to, again, we are spending public dollars, and we are one of the highest per capita spend healthcare system across the industrialized nations across the world, and hence our outcomes are quite on the bottom end, in the bottom third into the list in general healthcare, not just about mental health and substance use, and many other healthcare areas. So we need to wake up. The politicians, the policymakers need to wake up and say, guys, whatever we are doing is not really make a value add proposition or an impact. So we have to do our crisis management. At the parallel, we have to build a system that's going to be working on the next decade, meeting the needs for the British Columbians and the Canadians. So that's the missing piece. And then the missing piece is transparency. To me, like we don't have a dashboard provincially. We just talking earlier on, my colleagues were saying that here, the panel members, we're not kind of shouting and screaming every day what's happening, like COVID, what we did. There's no sense of urgency on that. And the culture is different. The stigma is attached to it on the overdose and mental health access. So to me, why would I not want to see, as a taxpayer and a publicly funded, free for all at the point of entry healthcare system like BC, where we are proud to say that we do that work, but we should also be proud and also be transparent to say what is working and what's not working. So I want to see something like NHS dashboard in England. I want to see NBC Health Services dashboard, which talks about not just the waiting times in ER, but talks about all the other quality outcomes and indicators. Until we see that transparently, then looking at neighborhood and seeing where we need to put our money and investment, which areas we need to work on. Is the access the biggest hot piece, or is it the treatment the biggest hot piece, or is it a combination of everything? So, or is it harm reduction? So where do we kind of put our money right now? And where do we put our money to build our system for the next 5 years? So transparent dashboard is really important. Then coming up with a strategic plan, no matter what the political cycle is 4 years, we need to have our organizations, nonprofit, academic researchers, and policymakers all come together and create together a strategy or a healthcare plan or a health services plan for BC, which would be 10 years. And we need to see first 10 years, this is the work, next 10 years, because we're not going to fix everything in the next decade. But we should say, okay, these are the top 30 priorities. Let's work on this top 10 the next year, next 5 years, and next 10 years, and keep moving forward. So that's what I would like to see. And I hope I would see that before my time ends in DC. So look forward for that very soon, working with all of you guys and all of the other institutions and collaborators.
Thank you, Dr. Vijay. That was very insightful, and I'm excited to see what the future holds. It's now 12:15, and we're moving into our lunch break. I want to ask the panelists, we did start about 5 minutes late. Would you guys like to move into your lunch break, or give the audience maybe a chance to ask one final question? Do you guys need to leave at all?
I don't need to leave.
Are you okay? Yeah, you're sorry?
I said, I'm good. I can sit here for the next 2 hours if you want.
Ask it time. So I just want to reach out to the audience and ask if anyone has any questions they'd like to ask our lovely panelists. Now is the time. You can either raise your hand or ask it in the Q&A box.
Just while we're waiting, I was going to say to Vijay that you're probably aware of the government's, the Ministry of Mental Health and Addictions Pathway to Hope. It is a aspirational document that really doesn't go anywhere, but that I think they think that's the plan. And anyway, just wanted to bring that up.
No, I fully agree, Leslie. But the important piece is like, we have an aspirational document, but what are the tangible and measurable outcomes we're going to achieve? And is this going to kind of meet the demands for our 10-year period, what we really need? And I do see this focus on priority areas and priority population, but I do feel that document does have the missing piece in the large system level work across the continuum. I mean, to me, like, I keep boring that. It's just not individual pieces, it's an across the continuum. And I do feel there are gaps in that, and also not very clear outcome-based or measurable outcomes that would be shared in a dashboard format across the neighborhoods, across the province. To me, like, I want to bring that back again, that we need to be transparently sharing that work, not just every 4-year an election cycle.
Thank you, Vijay and Leslie. There's an incredibly insightful question from an audience member that I thought maybe we can just have like a 1-minute response from all the panelists. But the question is, despite the progress made and inspiring advocacy discussed today, what can researchers and advocates do to maintain a compassionate approach to treatment in a time where more punitive approaches are being called for? So if you guys have maybe any brief thoughts on this, please feel free to share.
I can respond to this one. To me, the answer lies really in the evidence. When I think, like, does a punitive approach work to treat an illness? What does the data show us? And I don't think there's a lot of evidence that shows that punishing people is helpful when they're ill. I think that when we look at mental health and substance use, we can't separate it from the early childhood trauma, ACEs, and treatable mental health conditions, which really are the base of, I think, a lot of what we're talking about today. You know, if going to jail worked, we wouldn't be in this problem. If a punishment worked as an effective solution, we wouldn't be where we are today. We only need to look further south to see the number of people incarcerated for mild substance use issues. So to me, that the evidence is there, and it also goes back, I think, again, to what Leslie talked about with stigma. What other illnesses do we talk about a punitive approach? Like if someone had diabetes that was uncontrolled, as a society, are we talking about them not going and eating bad food? Are we punishing them? Or are we talking about engagement, collaborative problem solving, motivational interviewing, working with them, overcoming the underlying barriers? And so I see this as a really important theme to talk about. And unfortunately, it is still very much part of the day-to-day, I don't know, social media society, when I think it's really old news. Punitive approaches.
Thank you, Dr. Russell. That was an incredible response, and it was a great reminder as to why are we doing the work that we're doing, like what is effective, kind of, yeah, just connecting it back to what the aim is of all of this. So thank you so much. I have been informed that I do have to end the session now, although I wanted to hear from all the other
But
panelists.
wait,
Leslie, you can definitely chime in here.
we have to look at our present politics. I mean, you know, EB wants to lock up people who, you know, are prolific offenders. Everything they're doing is for the public's feeling of safety, not for the people who are in crisis, mental health and substance use. Sorry. Okay.
No, thank you for adding. That was an important add-on, and I'm glad you did it. I'm glad you mentioned it. I mean, so yeah, I just want to thank all the panelists, like profoundly, for your just insight, for your stories, for everything. This was one of the most moving workshops that I've attended. This is my third conference with the group, so this is one of my favorites for sure. So thank you all so much for being here, and for the audience members, thank you for your questions and your engagement. So now is our time for our lunch break, and feel free to take some time to self-care, and we will see you in our next session. Thank you again, everyone. Take care.
Pleasure. Thank you.
It was such a pleasure.